Hello Real clinicians and welcome to this EndoMasters 2016 presentation. This is Ali Nasseh and it's a great pleasure to be with you here today for the next hour and share with you a recent presentation that I gave at the American Association of Endodontists meeting in San Francisco. I figured that this presentation titled MTA versus Bioceramics would be of some general interest to everyone, so what I'm going to do is to share it with you over here. I was asked by the American Association of Endodontists about a year ago to present on this topic in the format of a debate. So I was supposed to basically present for 20 minutes on this topic of bioceramics, and then somebody else was supposed to go on for 20 minutes and talk about MTA, and then we were supposed to have a roundtable discussion with questions and answers from the audience. However, about a month right before my presentation, I was told by the AAE that I had to present both sides of the debate on my own. So I was obviously very surprised since I hadn't prepared to talk about MTA, even though I had used it since its inception since 1994, all the way till 2007 when I finally converted to BC Sealer and the putty. However, thinking about the title for a minute that they had chosen for me to talk about, I understood why MTA versus Bioceramics is really a redundant title. And it's because MTA is also a bioceramic, which made me realize why no one came forward to accept this debate challenge. And so the panel discussion was canceled. So for the sake of fun, I assumed that if there was a debate on this topic, it would have probably gone something like this. Hey, buddy. Hey, what's up? Not much. All's good. Great. I'm sorry, but what are we doing here again? Well, we're debating MTA versus bioceramics. Oh, I see. That's wonderful. But wait a minute. Isn't MTA a bioceramic? Yes, it is. Okay, then what are we debating again? Well, MTA versus bioceramics. I'm confused. That makes absolutely no sense to me. I know. Well, I didn't choose the title. I thought you did. No, I didn't. AAE chose the title. Anyway, let's just give it a shot either way. Okay, whatever you say. Okay, so MTA has been the gold standard for the past couple of decades. There have been thousands of surgical cases that have been done with MTA. There's lots of research that's backing this material. Yes, that is true. MTA is a wonderful material. Hey, it's a bioceramic, so it really must be good. But this formulation has poor clinical handling properties, and actually bioceramic putty is a calcium silicate phosphate bioceramic, just like MTA. Lots of research is also backing it too. And also the research that applies to MTA also applies to the putty because they're basically the same active ingredient. Yeah, but MTA came first and is therefore better suited for surgical applications. The putty is a pure bioceramic developed from scratch to optimize its use in biological applications rather than building concrete walls with Portland cement. Touché. So you're telling me that they're both bioceramics with the same base chemistry, except that one is a purer form and has an easier clinical delivery method? Yes. Oh, for goodness sake. This is a pretty lame debate. So why don't we just scrap the whole thing and go have a beer? Now, that's the best idea you've had all day. Okay, that sounds great, but you're buying. Okay, so as you can see, the chosen title is actually redundant. And as a result, I gave this presentation primarily on the role of bioceramics and endodontics, specifically the BC Sealer brand, and its indication, and more importantly, the philosophy behind these compounds that help us redefine endodontic therapy, not only surgically, but also more importantly, from a non-surgical point of view. So let's get to it. You know something, I've actually given these types of formal presentations over 200 times over the past few years. So I think it's really time to try something new for this specific presentation. What do you think? So let's give this a shot here and do something new. Okay folks, why don't we try to do this in a vlog style. We're going to go on a little field trip. I'm going to try to basically talk about the same presentation, but a little bit on the move. We're going to do this in a YouTube style, so we need to have somebody as a little bit of a character. So here we go. We're going to try to make this exciting and interesting. If you're ready, let's go. It's my office over here, and we have a few people working, and as you can see here. Alright guys, I'll be right back.
So we had a recent problem with a little bit of a flood. So we're going to now leave the office and head out. I'm gonna try to see if we can do a little field trip outside, show you guys a little bit of Boston, and also talk to you guys a little bit about Bioceramics. All right, so let's get going. Okay, so what we decided to do is we're going to talk about Bioceramics, and most particularly about this brand of Bioceramic that we have. There's several different Bioceramic compounds that are available, but we're going to be talking about the BC Sealer Putty, and they're used for surgical and non-surgical uses. So let's leave this building here and get on the road and talk more. Okay, so we're going to pass through this dark alley here. Well, I'm going to talk to you about my first presentation that I gave at the AAE in 2009. It was a Master Clinician Series presentation on various obturation techniques, and I was discussing the role of sealer-based obturation, and I basically presented for the first time on this topic of hydraulic condensation and where it could be helpful. Well, then you should have seen the audience's response there. Everybody was looking at me like I had two heads, because up until then, the only way we had been told we need to obturate canals has been through the use of vertical or lateral condensation, and everything below that was basically substandard. So what ended up happening, I got a lot of responses saying, how could you have used single cone obturation technique? This is terrible. How can you just place a cone through a massive sealer? That's going to fail. We've been told we need to do vertical lateral condensation, all kinds of things. So basically what I'm going to do in this presentation is talk to you about the various ways why this type of technique works, and then do a couple of demonstrations. So the modern bioceramic technology could be used in several different fronts, both non-surgically as well as surgically. What I'm going to talk to you about, and the objective today is to talk about primarily the non-surgical use of this material. As you will see, in other videos that I have done on our website, you can see basically many of the other uses of bioceramics. The non-surgical uses of bioceramic are primarily for a sealer, for obturation, and then for pulp capping, as well as epixogenesis, epixification, perforation repair, and some other uses as well. Surgically, you could use the material for apicoectomy, for surgical repair of resorptive defects, for perforation repair, and a whole bunch of other uses that the material comes handy for. So as you can see, the material really has a universal use for both surgical and non-surgical use in endodontics as a final reparative cement. And this comes in three different formulations that we're going to talk about. But first and foremost, I want to focus on the non-surgical use of this material, which means that for obturation. So before anything, let's take a quick look at a case instrumented and obturated with hydraulic condensation, so you can have a big picture view of what it's all about before we talk about the details and why it makes sense.
So we have a necrotic mandibular premolar with a periapical lesion, which we estimate to have a 19 millimeter working length. Here the bite wing shows the extent of the decay. As usual, we isolate with primary isolation with a rubber dam, and then flatten the cusps and remove the decay and all unsupported enamel, removing the additional decay with a slow speed, and then using ultrasonics to blend everything in. And now it's time for secondary isolation, which here I'm using a caulking material, and then just checking that we have some patency here and opening. Proceed to use the combination of EndoSync and EndoSync AI, which is the handpiece with OTR motion as well as an integrated apex locator. So as you can see here, using the expedite, which is the 1505, allows us to, in combination with the apex locator, allows the file to stop automatically as soon as it reaches the apex. So it's proceeding, as it gets close to the apex, it stops immediately at the setting that you essentially decide in advance. So you can do it a couple of times to confirm whether you have the true apex. And now we have the 1505 down, and using the ESX basic protocol, we know that we should be using, based on the number of engagements, a 4504 for this case as a finishing file. So we jump straight from a 1505 to a 4504 in this particular case, and proceed to basically move this down using the rhythm motion
with irrigation. We can use the endo swipe to clean all the debris that's accumulated in the chip space, and very gently using the SOTR motion along with the rhythm motion, move the file down until we have achieved the full working length with a 45. Now that we've created a shape, we can proceed now to disinfect the walls and clean them a little bit better using this XP3D finisher file. And here the goal is to create originally a shape and then use a finisher to disinfect the walls, which we haven't touched, using a round cross-section instrument. This instrument allows to have this whipping action of touching all the surfaces of the wall, and use it for about 30 seconds to a minute, and which we fast forwarded, and then proceed to use our combination of ultrasonics and then ultrasonic with a weak irrigation solution of sodium hypochlorite, and lastly using our negative pressure irrigation. And as you can see here, I'm basically throwing all the disinfection protocols at this tooth following the shaping. Now I'm fitting the matching endosequence BC cone with my final preparation size, and take a check radiograph to show whether we are seating the cone all the way to the end, which confirms that. Now all you need to do is really just to dry with your negative pressure. You don't need to do a lot of heavy dehydration, because you're having a hydrophilic sealer. You inject it in the upper half of the tooth only if you're using the advanced technique, and then the goal is to push the sealer down to the apex, for which you could use your master file, or here I'm just using the master cone. If there is additional space, you can just put additional cones next to it without really having to do heavy lateral condensation forces. So using the Endo Pro 270 at high temperature, sear off right at the level of the orifice without having to go too far down, and then use the largest plugger, here's a size 10 first, and followed by a size 9, to take the molten gutta percha and spread it everywhere, so that you end up with only gutta percha on the surface without showing any sealer interface. And by doing that, then you can clean out the sealer that is remaining using ultrasonic and water, and you're now left with only an interface of gutta percha without any fresh sealer showing. This allows you then to place your core immediately, or in my case, I basically send the patient back to the restorative dentist, and you can see here the final film showing that hydraulic condensation using BC sealer allowed us to pop this lateral canal and do very efficient obturation in this particular case. So we can't talk about endodontic obturation without talking about Dr. Schilder, the program director at Boston University. Dr. Schilder is really the person who put endodontics on the map with all vertical condensation, and he believed that the only way you can get three-dimensional obturation is through the use of vertical condensation. But even when I was a resident, the question that always came up was, what seals the root canal? Of course, the answer always was the sealer, right? So it's the sealer that's sealing the root canal. Well, if it's the sealer that's sealing the root canal, why is it that all of the mainstream techniques, including vertical and lateral condensation, talk about the pushing of gutta percha? Why are we pushing so much gutta percha? What's the point of that? Well, when I became a resident, it finally became clear to me that the main reason why we're doing all these pushing of the vertical and lateral and all different ways of moving the gutta percha is because of a study that was done by Dr. Grossman, where he looked at all of the available sealers that were on the market at the time of his study, and he found that all of the zinc oxide eugenol sealers and all the resin sealers that were available at that time were severely deficient in sealing the root canal. They didn't have any of the properties that he defined as ideal sealer material for obturating root canals. They all shrank, they all washed out of the root canal, they didn't bond, and so they had all of these problems when they pooled. As a result, it became an axiom to minimize the sealer interface whenever you're doing a root canal. So that means that the gutta percha was better than our original sealers, so we had to minimize the sealers that we had by pushing the gutta percha to replace the sealer. And that was really the beginning of our idea of obturation, and the axiom of minimizing the sealer interface has been the predominant theory that has been basically predominating the field for all of this time. So the question that comes up then is, what about bioceramics? All of this changed with the rise of bioceramics. And the first bioceramic that came on the market, we all know it, it was MTA. MTA is an excellent product, and when it first came out in 1994, it really revolutionized the market because it was the first time that we had a hydrophilic material that also had great dimensional stability as well as antimicrobial properties and all of those other things that we really needed to have. Of course, the particle size of MTA was very large, and the handling properties of the MTA was not quite as great because you would mix it up and turn into mud, and then applying it to the site always required additional armamentarium, so it was difficult. Plus, because of the particle size, it wasn't really available for the sealer material. And this all changed in 2007 and 8 when the nanoparticulate bioceramic material became available. And the first one of those was iRoot SP, which was developed with the sub-micron particle sizes that allowed, and also came in a pre-mixed format. So all you basically had to do is the material was the purest form of a nanoparticulate that was designed from the ground up to work for endodontics as opposed to Portland cement. So basically what ended up happening is that this material became very quickly a replacement for the modern types of sealers that we use for obturation. And people often ask me, well, Ali, I jumped on on using this material very early on, and the reason why I did that is because the chemistry made sense to me. So before we get into the clinical use of this material, I just want to share with you the chemistry of the material so we can understand why it makes sense and why I originally decided that it would be the right material for the technique that then later on developed to be hydraulic condensation. So if you look at all the bioceramics, they have a hydration and a precipitation reaction. In the hydration phase, the calcium silicate picks up the water molecules. In the case of the BC sealer and these nanoparticulate pure bioceramics, they pick it up from a surrounding because obviously it's used in vitro in an environment where we're 75% made out of water. And then the water reacts with the calcium silicate and produces the calcium hydroxide. And from that, we can immediately tell that the material is going to be hydrophilic. So you got a hydrophilic material that has the ability to be also antibacterial because of hydroxyapatite. And then what ends up happening is the calcium hydroxide slowly reacts with the calcium phosphate that's in the cement, and then what you end up getting is hydroxyapatite, which is the material that that is found in the vertebrate skeleton and is an integral part of the bone. So we can then determine, just looking at the chemical formula of this compound, that you have a material that is hydrophilic, that is biocompatible because of the hydroxyapatite that is produced as a final reaction. It has high pH, therefore it's antibacterial, as well as it produces an environment that is conducive for bone formation. It's dimensionally stable, and more importantly, that the hydroxyapatite, through cross-linkage, can do chemical bond with the hydroxyapatite that's in dentin, and you end up getting basically a material that bonds chemically to dentin. So you have a lot of different properties that are really, really helpful. And also, in this particular formulation of this nanoparticulate bioceramic, you have a pre-mixed formulation that is not requires any mixing, and you can inject directly into the tooth or put it outside on a pad and place it in the tooth in a very, very simple format. So as a result of all these improvements in the material properties of the sealer, all of a sudden the game has changed, and we don't have the limitations of the old types of sealers. So suddenly, as a result of these material improvements, we're not only just changing the way we fill a root canal, but more importantly, the way we do endodontics, because for the first time in our history, our sealer is actually a filler. So when it comes to comparing now fillers, you would say gutta-percha is a filler too. So what are the benefits of gutta-percha over a BC sealer or bioceramic sealers? Well, actually, to be honest, what we need to do is we need to really call BC sealer a BC filler, because that's what it really is. It's actually a filler. We call it a sealer from traditionally, which kind of confuses people to think that a sealer should have a minimized sealer interface. So as a result of these changes, the old concept of minimizing the sealer interface now becomes maximizing the sealer interface, because it doesn't have to be as small as it was before. But what are really the benefits of bioceramic sealer over thermoplastic gutta-percha? Well, first and foremost, bioceramic sealer doesn't shrink, whereas thermoplastic gutta-percha shrinks anywhere from 2 to 7%. You have bioceramic sealer, which is antimicrobial, whereas gutta-percha is not antimicrobial, it's just inert. You have a bioceramic sealer that bonds to the dentin, but thermoplastic gutta-percha doesn't bond. In fact, when it shrinks, it pulls away from the dentin, and that's the problem. Bioceramic sealer has better flow properties than thermoplastic gutta percha because thermoplastic gutta percha, when it cools down, basically solidifies and it's very hard to move it. It also shrinks, as I mentioned before. And last but not least, a bioceramic sealer is hydrophilic, whereas thermoplastic gutta percha is not. And that's a huge, huge issue because you're working in an environment that's 75% water, and that's inside a human body, obviously. So in order to understand this whole thing, let's go back and look historically about how these obturation techniques came about and what were the differences and how this idea of a new filler can change the game moving forward. Okay, let's start by the basic problem of trying to solve and fill a oval canal. How do we fill an oval canal? Well, originally what we did is we tried to come out and say, well, you can use a single cone in a sea of resin sealer or in a sea of zinc oxide eugenol sealer. Well, predictably, the ZOE basically shrank and it came off of the canal walls and created a lot of leakage, which is why the original single cone technique didn't work. So what we decided to do is to go and say, well, let's try to fill the oval areas with more of these lateral cones, which caused us to have a lateral condensation technique. We developed the lateral condensation technique to address that particular issue. Predictably, again, the same problem arose where you had shrinkage of the zinc oxide eugenol based sealer around these little mini cones, which actually may have in fact increased leakage at various different interfaces. So vertical condensation came about to address that issue by putting even more gutta percha in there and reducing the sealer interface even more. But then again, you still got the same issue of leakage even with vertical condensation because the gutta percha shrank again 2 to 7%, and also the sealer came off the walls as well. So the same issue. Of course, they were all better than the original single cone technique, but they were not quite as ideal as they could have been until this whole thing was resolved. Once this bioceramic sealer stuff came around, it improved our ability to create a filler that was hydrophilic and all the properties that I basically mentioned. So then we here at Rebuild Endo said, instead of filling the whole canal with this bioceramic filler, which would then make retreatment impossible, let's have a responsible technique, which included the use of a gutta percha that was cone matched with the canal in conjunction with the bioceramic sealer. And that was the birth of the hydraulic condensation technique, which involves placing a gutta percha cone that is coated with bioceramic particles so you can have the chemical bond of the bioceramic to the canal walls as well as to the gutta percha surface, and that's what basically caused the hydraulic condensation to come about. Now the question that comes up is, what about the gutta percha? I mean, comparing vertical condensation with thermoplastic gutta percha and the hydraulic condensation, we've got two different kind of fillers here. In one you have bioceramic, the other one you have gutta percha. The advocates of gutta percha now have the burden of proof to basically tell us what is really so special about gutta percha, and at the same time, what is so special about resorbable sealers such as ZOE or resin, which usually goes hand in hand with the vertical condensation. One thing I learned completely today is that doing these vlogs are not easy at all. Okay, so here's a little bit of a New England club chowder for you. So when we were talking about the different resorbable sealers, this was a case that was recently shared with me by Dr. Shervin Golian. And this is a case that Shervin did and had beautiful results immediately post-op using a resorbable sealer such as ZOE. Unfortunately, when the same patient returned the following year to do a different tooth, on the adjacent tooth basically, Shervin's x-ray shows that all of the original sealer that was expressed out from the lateral canals using vertical condensation, having that beautiful anatomy, had completely disappeared. And that is a little bit of a concern because resorbable sealers may give you an impression of doing a beautiful fill and all that lateral anatomy immediately at the time of the fill. However, just a year ago or so, all of that sealer has resorbed. So that's not really what we want. Okay, so why don't we just kind of drive for the rest of the way because it's just so much noise and background mayhem that it's just making this little vlog almost impossible. Okay, so this takes us to the hydraulic condensation technique using the endosequence. So endosequence technique was originally developed by Dexter's Caution Brave, and the idea was using active GP or a glass ionomer type of a cement as the filler to fill in the gaps when you cone match a preparation, a constant taper preparation, with a constant taper gutta percha cone that would be the carrier. So the idea there is that the glass ionomer was doing the original filler between the carrier and the canal walls. So when bioceramics became available, I figured why don't we use this bioceramic material, the BC sealer, to do exactly that. And that was the birth of hydraulic condensation technique using bioceramics. The idea, again, is to have the main cone fill most of the canal because it's cone mashed and it matches a constant taper preparation, and then having the bioceramic sealer as kind of a permanent filler here to fill in the gaps, because obviously not all canals are round and exactly the shape of your gutta-percha cone, so you need to have something that fills it, and that's where the bioceramic sealer comes into effect. So you basically have your BC sealer or BC filler, if you will, as well as some gutta-percha cones, constant taper gutta-percha cones, the endosequence cones, that are silanated on the surface so that they bond chemically to the bioceramic. These things match the endosequence files as well as the ESX files. So you have a variety of matching gutta-percha and paper points to the endosequence and ESX files, and you have this bioceramic sealer that acts as a filler to fill in the gaps between the main carrier cone and the canal walls. The idea is that you place some of the sealer in the canal. You can directly inject it into the canal the way we've described as the advanced protocol, or you can place it on the on a little pad and then gently put it into the canal all the way to the end. If you do inject, make sure you have a microscope. You can see how much you're injecting so you don't overfill the canal. The idea is to only fill the upper half of the canal and then push the sealer down with a file to the apex and then coat your cone and place it all the way down to the end of the root. This kind of technique is really the kind of cementation that you would have using a post. So this is a passive obturation technique. And the benefit of this particular type of a passive obturation technique is the idea that you're not really putting too much excessive pressure on the canal walls with your spreader or with your condenser. One of the biggest problems with those active obturation techniques in the past had been the idea that you are not only widening the canal too much in order to fit your spreaders and condensers, thus unnecessarily removing good tooth structure, but also you were putting active force into the root where right in the cervical area where you had thinned out completely because of your excessive taper, you would end up putting too much pressure and potentially crack the root. So this becomes almost like a post-preparation, because let's think about it. I mean, a post-preparation and a post-cementation is really the same idea here as hydraulic condensation, where you have one main post, or here one main carrier, and the rest of the obturation is really based on the cement. In this case of a post, it's a resin cement, which would be in the upper half of the root, where it could work because in the upper half of the root you have dental tubules, but in the bottom half of the tooth you really don't have enough dental tubules, which is why resin sealers would not work in the bottom half of the root, which is why bioceramics would be the ideal type of material here. So studies have also shown that you do get a nice chemical bond between the silanated surface of the specific gutta-percha cones, which is the endosequence and ESX gutta-percha cones, with the bioceramic because of the silanation. And then also you get a chemical bond to the dental wall. So in a sense, you do get this kind of a monoblock. However, the beauty of it is that this technique is retreatable because the main gutta-percha cone in the middle is soluble in chloroform, and then you remove that, and then you have just the rest of the ring of sealer around the cone that you would then remove by going one or two sizes up in your files, and you can use at the end some ultrasonics in order to shatter any remaining cement and remove it. Studies have shown also, independent studies at University of Alexandria, that this kind of cement will help you increase the fracture resistance of the tooth as a result of this kind of a bonding. And it really is the same idea as what we saw in restorative dentistry. In restorative dentistry, we went through a phase when we moved away from amalgam, which was a mechanically condensed kind of a preparation, which required dovetails and lots of undercuts in order to be retained, to a whole different kind of a Clark and Simonson type preparations because of the fact that we moved away from mechanical placement to chemical bonding. And this is the idea of minimally invasive preparation, where now we are bound by the rule that we only remove enough dentin to disinfect the tooth and remove all the bacteria from the tooth, and no longer remove additional dentin just for the sake of a obturation, which has been really the problem in the past with thermoplastic condensation techniques, which had required that we actually widen the tooth up way too much coronally only to accommodate our obturation technique, which was really unnecessary removal of dentin. If we could compensate, if we could change our obturation technique with a bonded type of a preparation, then we get away from that unnecessary removal of dentin. Okay, so let me share with you now the first case that I ever did using bioceramic technology and hydraulic condensation clinically. So this case I saw in April of 2008, and it is actually the first case done with bioceramics, and I know that because this case was done virtually the day after the material was FDA approved. Now, I say that emphasizing that, before you take any material clinically, you have to do a bunch of extracted teeth. And as we do here with the residents at the school, at Harvard Dental School where I teach, we have everybody do a bunch of extracted teeth before they see any patients. And anytime you get a new technique, you really have to be conscientious in trying to make sure that you apply the technique on extracted teeth first before you do it on actual teeth. And basically what I did here is I did a bunch of extracted teeth first, and then I took it clinically and I did this case. And as you can see here, this was a case of a second molar that was diagnosed with irreversible pulpitis, and as a result the tooth had to have root canal therapy. I started the root canal therapy and obviously enlarged the canals to a fairly large size, as you really should, as large as you possibly can, and then fitted my gutta-percha cones. I had size 40s and 50 here in the distal, and because the distal was kind of oval, after placement of the sealer, I did also place a couple of additional cones next to it, and then I seared off at the orifice level and then placed the hydraulic condensation right at the orifice level. This is the immediate post-op, but the patient never came back, unfortunately, for a follow-up until very recently. So this kind of gives a chance to do a many-year kind of a follow-up on it. And you can see that after many years, the tooth was asymptomatic completely. So the patient came back to treat the tooth adjacent to it, which you originally saw had a lesion, but it was asymptomatic, and the patient never came back to treat it. Unfortunately, when the patient came back to treat that additional tooth, it was too late, and the tooth had been cracked, so that tooth had to be extracted. But the tooth that was originally treated with the bioceramic was still there and was doing just fine. I have actually done many cases with this technique. In fact, it has been actually since 2008 now my exclusive technique. I have done over 5,000 cases using hydraulic condensation and cone matching with the endosequence, and then later on with the ESX system, and I have had excellent results with them clinically. Obviously I have a private practice, so the results are important to me, and I work with a lot of big prosthodontists and so on in the city, so that the results have to be great. So I can basically tell you from my personal experience that the technique works in the long run, which is really the important thing that we all care about. So what's the benefit? The benefit is that it's simpler and it's more efficient, and I actually am willing to contend that the quality of fill you get because of bonding is in fact better than just mechanical condensation you get with the non-bonding cements such as ZOE or resin type cements. So some people argue with me and say, well, Ali, this is a single cone technique, you can't be using it. Again, remember that from what I described earlier, a single cone technique here is referring to the use of a O2 taper gutta-percha cone, originally in a sea of resorbable and shrinkable sealer such as ZOE. So when you're using hydraulic condensation, it doesn't, with a bioceramic, not a particular type of a cement like the endosequence BC sealer, that it doesn't apply to this. So it can't be a single cone just because you use one cone and it's cone mashed and you're using a different kind of a filler instead of a resorbable sealer. You can't just, it's not comparing apples to apples. So let's look at a clinical case, for example. This patient came to see me because the patient was referred for an apicoectomy on the canine. It's obvious looking at this that you can see a lesion on the side of the tooth, and you can see there's a very weak fill. This is an original type of a single cone technique where the patient had a very weak gutta-percha cone in a canal that apparently was very much larger than that. So what I did, instead of doing an apicoectomy, which would not have a good prognosis in this particular kind of a case, I treatment planned the tooth for non-surgical retreatment, in which I went in there and I treated the tooth, getting it enlarged to a large enough apical diameter using an ESX 55, and then taking a matching cone, and you can see here as soon as I place the cement, the sealer, and I place the cone through it, I'm already picking up some lateral canals here just from the mere act of hydraulic condensation. And here's the tooth immediate post-op, and you can see all those lateral canals are filled with just that one cone in the middle, and then a 2-year follow-up showing great healing in this tooth. So you may say, Ali, what about extrusion? You said that the material is non-resorbable. What if you actually get some of it out in the form of a puff? Well, here's the bottom line. The material actually comes to us from orthopedic medicine, so it's actually a bone cement. So if you do get a puff, despite the fact that it doesn't look so good, obviously, to have any material outside the tooth, because that's not really the purpose of a filler or a sealer. The bottom line is that it heals. It heals because it's biocompatible and it turns into hydroxyapatite, so there's no reason for it not to heal. But if you do hydraulic condensation properly, the way we teach it at Reworld Endo, you shouldn't be really having any overfills. And at the most, you're going to have a little bit of a puff. But the puff is not a problem. Of course, it will over time, but it takes many years compared to the resorbable sealers that could actually wash out in a month. It will get remodeled along with the bone, so that won't be a problem at all. Also, what about the way the cases look? Well, cases will look pretty much the same, in my opinion, as vertical condensation, because all of these cases that you can see here have been done with hydraulic condensation, and they look pretty good, just almost like a vertical condensation technique. The key is just make sure that you have the right match for the cone and that you allow some room for the sealer to escape from around the cone. I have done, as I mentioned, over 5,000 cases now already with this. Nationally and globally, over 7 million cases have been done with hydraulic condensation. So this is really no longer a fringe type of a technique. It's a well-established technique that is used globally and is very, very accepted. But how about those people who prefer to still use it with vertical condensation? Well, we have now developed a new kind of a gutta-percha pellets that you could use, and as well as a new gutta-percha cone that has a lower melting point, so at 150 degrees Celsius. So the two can be used in combination to use this technique for hydraulic condensation, because still a lot of people prefer to do vertical condensation for whatever reason, just call it a habit, because I really don't think so. But you can sometimes get a little bit more hydraulics to push the sealer, and some people like that look, like that, you know, all those lateral canals being filled and the type of a denser look that you get from a vertical condensation. So now you can do that using not hydraulic condensation, but using the sealer or filler in combination with this lower melting point gutta-percha, as well as bioceramic pellets in a gutta-percha that you would use in your own existing thermoplastic gun. And you know, here's a case that I want to share with you. Obviously, this is a case that's not so easy to treat. This is a difficult type of a case, a difficult anatomy, as you can imagine. You would need to have a little bit additional force to push the gutta-percha. So we now have these pellets of gutta-percha that you can use in your obtura gun in order to backfill. So cases with this kind of anatomy, I use the idea of flattening the cusps first and then using lots of available length to move my way down after doing adequate orifice opening and then moving the files down. So here what we're going to do is, again, using SSC and cleaning the debris out of the flutes, moving my way down. We're just going to show you very quickly and fast forward, because the instrumentation here is not the part of the deal. But as you can see here, with just 45 minutes using a combination of different tapers and hybridization of taper, we've already been able to fit in gutta-percha cones. Here I'm using 20 in the mesial and 40 in the distal, and then using the advanced technique and backfilling, you can see you get fairly dense fill and get those lateral canals that vertical condensation people love to see and get the results that we want. Of course, the question of retreatment is also important to answer, and that is clearly a point of concern with this technique, but if only and only if you are using the cement to do a cement fill. If you fill the entire canal with a cement, then it will be difficult to retreat, no question about it, especially if it's around the curve. But the hydraulic condensation technique that we've developed here at Reworld Endo is in fact a responsible technique, which is meant directly for this purpose. The gutta-percha cone that is used in hydraulic condensation only has two purposes. The first purpose is that it helps carry the sealer all the way down to the apex, so it's not so difficult to fill the whole canal with it without getting voids and also overfilling or underfilling it. So the gutta-percha cone is a carrier that carries the cement all the way down. Additionally, what the gutta-percha cone does is it helps act as a path for retreatment. So you remove the gutta-percha with the cement, with any of these solvents, gutta-percha solvents such as xylol or chloroform, any of those guys, and then you work your way down, and then you go up a couple sizes and you remove the rest. So what about research on this material? Well, there have been a lot of research that's already been done. The material has been out now for a while, and there's research coming out every day, and all the research is basically showing the same properties as bioceramics have, which is the same thing as as MTA, as well as this material, all pretty much the same for the most part. You can actually go to our website and a little, on a little link. I have compiled all the research. So if you want to get a hold of that research, you can go to the link below and check it out. So let's get to the use of surgical use of bioceramics, because that's clearly an important one as well. So when it comes to that, as a result of these different formulations of the putty as well as the RRM syringeable material, we've been able to develop a specific kind of a technique called the lid technique that helps you use the benefits of these pre-mixed bioceramics in a way that helps improve the efficiency of your retrofilling technique. So the technique that we developed to improve retrofilling efficiency is called the lid technique, which involves the combination of using a syringeable material, which is fluid, acts almost like the light body impression material, in combination with a putty material, which then acts like the heavy body impression material. Do you guys recall from PROS, what you do is you use the light body impression material to capture the detail, and then you use the heavy body to push the light body into place, and also to kind of prevent it from moving around. And that the same thing happens here with this combination technique of the lid technique. And I've been using this right from the get-go, basically, right as soon as we developed the putty material. It was meant to do this particular thing. Originally, people were using the putty to fill the whole canal with, but that really didn't improve the efficiency gains that you could have when you move up from MTA to this material. The best way to use this material is the following technique, the lid technique, which involves injecting the syringeable material into the retropreparation and then using the putty for a protection cap up on top of this material. Because they're both the same base chemistry, they will interact and they will basically fuse to each other. But because the putty material has some components that increase its washout resistance, then also the putty is fast set, and it sets in about anywhere from 5 to 20 minutes, whereas the syringeable material could take 4 hours to set. What ends up happening, if you fill the whole thing up with the syringeable material and then you close your retrofilling, the blood will come in and basically wash out the material because it hasn't set yet. But if you use the putty as a cap up on top of it, the putty will act as protection for the material to set. You don't have to wait till the putty sets. You just basically place it and you're done, which means that your retrofillings are going to take a tremendously short amount of time nowadays to complete than it did before. When you use the MTA or amalgam, any other material that you use, you had to serially condense the material. Now you basically inject the syringeable material, which could be either the sealer or the RRM syringeable, and then just place a thin cap of the putty fast set up on top of it to protect it while it's setting. So we've developed these specialized tips for delivering the syringeable material all the way down to the end. The key thing to remember is that you can't inject the sealer material right from the cavo surface orifice, because otherwise you're going to trap voids in there. The same way with your backfilling with your obtura gun, or placing your core material, you got to take the nozzle of that syringeable material all the way down to the base of the preparation and then back up so that you don't actually trap any voids. And the same thing happens with the tips that we have created. So we have tips that have different diameters and different lengths that allow you to achieve this end, which means no matter what your retro preparation diameter is, you can take the nozzle all the way down to the end and then fill up. These tips come with different lengths, and in fact the plastic tip that is for anteriors and premolars that is 6 millimeters long can actually be trimmed down to much shorter lengths, and so you can custom make the tip to fit exactly the retro preparation that you have. So that is a tremendous gain in efficiency. With that, let's take a quick look at a case where it's been applied. So let's take a look at this case here. This is a maxillary first and second premolar with posts, and both have apical problems here. And as you can see, there's an extrusion near the sinus in the second premolar, and also a lesion at the end of the first premolar. So we do a kind of a papillary preservation technique for the incision here, and as you can see here, we're reflecting the flap here while preserving the papilla, and then we proceed to make our osteotomy. And the osteotomy is done using just a round burr with a very high torque electric handpiece. I'm using the Forza handpiece, which is an electric 45-degree angled handpiece, followed by the Lindemann burr to flatten the end of the roots. Once the end of the roots are flattened without any excessive bevel, then I'm able to use my ultrasonic tip. You can use whatever ultrasonic surgical tips you have. I use the best 1 and 2 tips by Brasler, and then you just go 3 millimeters deep into the retroperforation, as you can see, and you have nice and clean retroperforations, and you check to make sure gutta percha is all gone, and then you basically place the injectable material, making sure that the tip of your nozzle goes all the way down. As you can see in this technique, because it takes so little time to fill these canals, you require minimum use of chemicals for hemostasis. After you've injected your material, the syringeable material in the dry conditions, if you get a little bit of blood in there while you're putting the putty in there, is not as important. But during the placement of the syringeable material, you have to make sure that you have a very dry field, which will really take only about 10 seconds. So you can see the second one is done, and now we do the first premolar in the same exact way, injecting the light body syringeable material, followed by very quickly proceeding to place a little ball of the putty in there, and then remove the excess with a micro brush, and then using a little bit of water to clean out any debris. And you can see very quickly that we did both of those 2 teeth, and now it's time for the suture placement. I use gut sutures because they're self-resorbable, and the patient doesn't have to come back right away, and we can follow up. This is a pre-op and then a post-op, and as you saw very quickly, 2 apicoectomies on these 2 teeth were done, and the patient did very well with them.
Also, as you can see, you can use this tip now and remove all the gutta percha all the way to a post in an anterior tooth, for example, and then fill all the way back up and fill the root canal space all the way from the post up using these longer tips. So that's a tremendous amount of benefit, and here's a case that you can see that has healed beautifully in follow-up. And also in molars, these tips allow you to have the bendability to basically shape it to be exactly the right angle and the right position, so that you can go in there and, especially in these lower molars, quickly retrofill your cases, which has been really the challenge in the past. So that today, using these techniques and these tips, my assistants love doing surgery because it really tremendously helps the efficiency of our cases. Okay, so I'm here now in Cambridge, right in the Harvard Square area. I'm heading out to the Harvard Yard in a second. And every time I come down here, I pass for law school, and it reminds me of a student that I saw not too long ago in my practice, which is the case that I'm going to share with you guys next.
Now, this is a case of a Harvard law student that was referred for a perforation repair at the cervical area. They did a root canal therapy for this patient, and unfortunately had they did a cervical perforation, and we had to go in there and repair this area. And you can see at this point we've reflected a flap, and we can see the subcrestal bony defect that has been caused as a result of this perforation. And now we're just removing the gutta percha. They used the thermofill in this case, and the gutta percha was extruding out, and it was removed using ultrasonic. And now a microplugger is used to push that gutta percha in to give myself about a 3 millimeter thick cylinder of clean dentin that I could then use to bond my bioceramic in place. I'm just using optimized iodine to disinfect the area to make sure all the remaining area is clean. Now just washing and drying the site completely. At this point, it's important that when I'm injecting that there is no blood. So injecting in and then slowly out, and then placing the putty. Remember, at this point, everything has to be completely dry. But now, once I put the putty in there, a little bit of blood gets in there. It's not as big of a deal because that part is sealed already. So the blood would be basically on top of it. So anyway, now that we have placed the putty in place, this is the lid technique, and the lid is cleaning, keeping the syringeable material safe, and it allows for the material to set. Then use a micro brush to loosen up the flash, and then water to rinse out any of the remaining flash in the area. Dry it,
And in this case, you can see these were veneers that were not done very nicely for this patient. There's that gap that always will create a little bit of gingival marginal gingivitis. So this is the immediate post-op. The case healed very nicely. This is 6 months later. You can see great healing there. Unfortunately, the apex was failing. I should have really redone the whole root canal in this case because apparently they didn't do a good job on the regular root canal part either. So we do a submarginal incision here so we don't have to disturb the area above here, and do the same lid technique now at the apex of the same tooth, using the injectable material to inject into the root and then slowly back out as we're injecting. And then once we have filled all the way to the top, then you can place a little ball. Here in this case, I use the cone here of the putty, but you don't have to use a cone. You can just place a little ball of it. It's a little bit faster and it provides less manipulation of the putty. Make sure you always have clean gloves at this time because the putty should not really be manipulated with hands that have touched the patient's lip or face and have a smear of bacteria on them. So then place as usual using the little bit of microbrush to clean flash, and then wash out the remaining debris. And here it is, completely done, cervically repaired as well as apically repaired in this case for this patient.
Okay, now that we've talked about the surgical and non-surgical procedures such as apicoectomy, let's talk about the repair of perforations using bioceramics. Okay, when it comes to perforation repair, what you need to do is you have to understand that the most biocompatible material is the one that has to go against the tissue. So what you need to do is you need to place a putty or whatever bioceramic you're putting has to be as pure as possible, and that's the material that's going to go against the tissue. Whether there's a vertical perforation or perforation to the side, you need to use the putty material as a base. But then most of the time in the past when we've used the MTA in this place, we've had to place a wet cotton on top of it and have the patient come back again so that they can then, for the material to set. So a trick that you could do in order to avoid a second visit would be to place the putty at the base and then place a thin layer of light cured glass ionomer or a hybrid glass ionomer up on top of it, and then cure it immediately, and then you're ready to go. You can complete your case, and then at the very end you can use that glass ionomer layer at the surface to etch it and then bond your core material to it. And that will be your perforation repair. Remember that the key to the success in perforations is immediate repair. And that has to do with not letting the perforation site get contaminated by sending the patient back. As soon as the perforation occurs, repair it right away. And for that purpose, a pure bioceramic like the Endosequence BC putty would be the ideal material for this particular use. Okay, I think we come to the conclusion of this course. Now, of course, there are lots and lots of uses for non-surgical and surgical use of the bioceramics, as I mentioned earlier on at the beginning of the presentation. Unfortunately, with this setting, it's very difficult to get into all of them. I will have more of the examples of the different uses, whether it's in the non-surgical side of pulp capping, apectogenesis, apexification, one-step barrier technique, and perforation repair, non-surgically as well as surgically, and all the apicoectomy and the lid technique examples are going to be on the website, so you can check them out. We all learn our lessons. I couldn't obviously get through all of them through this type of a format. I now know why I did the original 200 videos in the controlled setting of the studio. It is a nightmare to try to get to do these things in this kind of a run and gun setting with the audio and the sound and the wind and all the distractions on the side, and be able to focus. I'm just hoping that this presentation was helpful to you, that you were able to get enough information out of this that it could help you understand the place that bioceramics have in not only in the surgical aspect of endodontics, which has now been well established, but also specifically in the non-surgical component of our procedures, which will help you hopefully not only increase your efficiency in terms of your obturation for your patients, but also your efficacy through being able to create more conservative shapes and preserve dentin in a more minimally invasive fashion. Now, I hope that we're all on the same page in understanding that your success doesn't really come from the material you use, whether it's a bioceramic, a ZOE, or whatever material that you're using. Your cases will not succeed as long as you're not doing the proper cleaning, shaping, and disinfection of these cases. So please don't think that any material out there is magic, that is going to allow you to do something in a shoddy way or get away with less than perfect and idealized in disinfection and shaping of your canals. So keep that in mind so that I don't come across telling you that if you just use the Bioceramics and specifically the species sealer and total film materials that you're going to have 100% success rate. Your success rate will be more of a function of your meticulousness in your ability to clean, disinfect, and fully render your canals as sterile as possible, and not related to any material that you use. I will say goodbye to you. Thank you so much for your attention, and visit us at rebuildendo.com, where there's going to be a lot more content. I will be adding a lot more of this material on there. I will probably put this video on our website a few months after we release it here, so you can check it out over there, and we'll have probably another video on this material soon. For Rebuildendo, I'm Ali Nisse, and I hope you found this information helpful.